Good afternoon. I'm Omar Saab, one of the medicine faculty in University of Texas Health Sciences at Houston. I'm hosting this webinar. It's the second webinar titled Tips for Interns and How to Succeed in Residency. We have a moderator with me, Marwell Judy, and the presenter is a unique friend of mine. He's an excellent doctor, will give us from his own experience. Of note, we are not representing our home institutions or any agency. This is completely voluntary work. We are aiming to help our colleagues who are starting residency, and we wish you best of luck. Marwa, you can introduce yourself, and then Dr. Baldawi will start his presentation.
Hello, my name is Marwal Goody. I'm one of the incoming preliminary internal medicine residents at Hackensack Emergent Health, Jersey Shore Medical Center. So I'll be one of the moderators. I will share your questions with Dr. Beldawi. You can write your questions in the Q&A section. Anything that comes into your mind, it will be completely private. Your questions in the Q&A section will not be seen by just by us, the host and the co-host. But anything you write in the chat will be public. But Q&A are private. Chat is public. So you can ask anything you want. I'll be sharing those questions with Dr. Beldawi, and he will answer them for you. Thank you, Dr. Baldawi, for coming, and we really appreciate your time.
Thank you. Hey, my name is Mumar Baldawi. So I worked at a few hospitals, actually about maybe 8 or 9 by now. My most recent full-time job was at Ochsner Medical Center. And I have held a few positions from managing the, working with residents. Didn't really work with residents exclusively. It was part of the part of the job if they needed anything. To managing rural areas to I'm sorry, working at rural areas to doing night team to just about anything. So anyhow, this is my take on the basics of internship, okay? And I put a disclaimer on this slide. This is my opinion. It's based on my observation and experiences, okay? Some other attendings or some other doctors would have other opinions and, they would approach it differently. And also, each program is designed a little different than others. And each program has their own culture and a set of rules and expectations. So you really have to be, um, it's your job to know what those rules and those expectations while you're doing the interview. And if you did not have the time to, or if you missed, a few points, or if you aren't sure what the program culture is about, you need to find that out the first week, not, by the end of your internship. Also, each attending, like I said, they have their own set of rules, and you just need to know that. You need to ask your upper or ask your peers who have worked with them and just tell them what was this physician working with? What do they expect? What do they want me to say during the presentation? And we'll get to that in a minute, okay? And the most important thing is you all are starting a different starting line. So some of you know more than others. Some of you are fresh graduates. Others have graduated a long time ago. Some have worked as doctors. Some have not. Okay. When you go there, you might find someone that says something smart. Don't let that discourage you. They just may know more than you do. Okay. And they may be smarter than you. But that's not something that should discourage you. You should just adapt very quickly and move on. Okay. No one is going to pick on you for not being, the best, but like we are going to get to in a minute, there are a few things that you are required to do that you need to do. Okay, you have to be the best, obviously, but I don't want you to be discouraged from day one for not being this, for not knowing as much as everyone else. Um, during my first year in medical school, uh, one of our physicians, I'm sorry, one of the professors, he was a physician. He was an older guy. That was actually the last year that he taught. Think he was maybe, I think he was in his late 70s. He practiced for a long time. Anyhow, he asked the first question in the class is, who lives by a philosophy? Or do you guys live by an instinct? And, many students raise their hand that they live by philosophy, most of the students actually. And it's really, it was a really good question. I still reflect on that question to this day. Um, you find out things as you move along and you learn things and your philosophy change about how you approach medicine. So this is something I want to start the presentation with because it really defines of what you need to be thinking about when you're going about your day and just about everything, from seeing patients to chart checking to everything like that. You need to have a goal. You need to have a mindset. Going by instinct and is not necessarily something you can live your life without. Sometimes you feel something is not right. You have to trust your gut, but sometimes you need to have set of goals and set of values or philosophy that you live by. Okay, maybe the word philosophy might entail more than what I'm describing, but this is how I interpret it. So the way I approach it is that um, the way I approach it is this: for any task you're required to do, you need to know what you're asked to do, what you need to do. Okay, so starting as an intern, you need to know your what are you asked to do in that program. What are your to-do list, or what is the expectation? Okay, what are your duties? Just like any job you apply for, there are duties that you have to fulfill. Okay. And also the program has duties to you, or the program needs to fulfill things to you. So you need to understand that relationship very well. First thing, what are the requirements of the program, or what is the duties of the program toward the interns or the second year or third year? There's some misconception, not all, but some um, of incoming interns that they believe that the program is going to teach them medicine, and that's not true. The program cannot teach you medicine. You've been to medical school for that, right? So the basic medical knowledge is not something that you're going to expect the program to teach you. But they should be teaching you stuff for the board related, okay, or at least provide you with the tools to learn about the what you need to know for the boards. Um, treating patients from A to Z, or at least until coming up with a plan is your duty. Okay. Do not, you're not supposed to go and ask people simple things. You should be able to figure that out or find that out by yourself. Their job is to provide you a safe and supervised environment to apply what you learned in medical school. So you learned how to treat hyperkalemia. Now you have a patient with hyperkalemia. Apply what you learned, and you got an attending and an upper that can guide you through it, but you have to tell them what's your plan. Okay. So let's go to the requirements of an intern. So the main categories that I want to focus on is patient care, communication, and professional development. So each category offer opportunity for you to spend time and learn or build your career. Okay. Let's start with patient care. I try to divide it in a way that's easy for me to present. And, there may be a better way to present this, but I think this is, I try to make it easy for incoming interns to try to streamline their work day, so to speak. So when you get a new patient, you're probably going to get a text from your upper or your attending, depending on who you work with. And then they tell you, hey, let's get a patient, a 50-year-old, and the ED presenting with XYZ, presenting with shortness of breath. Sometimes they give you more information, like they say, oh, the patient has pneumonia, or this is, an easy patient, has got this and that. Okay, sometimes they don't. They just say, hey, this is someone with shortness of breath. You need to go see this patient. The first and the most crucial step is that you need to do chart check. And chart checking entails just about everything in the chart you're required to know. Okay. If the patient was, if the patient is a frequent flyer, if they've been to the hospital 4, 5, 6, 7 times in the last year, try to establish a trend. The patient comes in every month for overload, okay, for fluid overload or volume overload, and then you need to try to understand, is the patient picking up their medicine? What are the barriers? Why the patient keeps coming back? Okay, so you need to be asking yourself all these questions while you're chart checking. Oops. And that's just a tip of the iceberg. I mean, there's so much you need to understand and learn from chart checking. You pretty much need to know everything about the patient, their past medical history. You need to look at what medicine they're on. You need to look at, sometimes they come in, I look at their blood pressure and I see the blood pressure is soft. I'm looking at the patient now, he's in the ED with a blood pressure of 92 over 58. And I tried, there is a search button in Epic. I'm not sure if all of you guys are going to be using Epic, but there is a search button in Epic at the very top in the middle, at the center. And I just write blood pressure. And every time the patient has been here, it's been recorded, it's gonna pop up on that search. And I look at the trend, I'd be like, the patient is usually hypertensive. What's going on? This is a really, like if the patient is here and their lactic acid is really high and they meet search criteria and they're septic and all that stuff, I'd be like, oh, this is really bad. The patient is not at their baseline. So I kind of already created a pattern. I already start to understand the patient that he is usually hypertensive and now he is hypotensive. So anyways, chart checking gives you a lot of information. This is the most crucial step. There's no step that you can skip, but this is the most crucial step for you to understand what's going on. And then once you have read everything the ED has to say, read all the notes from and again, sometimes if the patient has been here 100 times, they're not going to read every single note, but just try to develop a pattern to why the patient is usually here. And you've kind of created a basic understanding of who's the patient and what's the patient usually here for, what is this time, why did the patient come to the hospital this time. And once you create all that, and then you go and you see the patient, okay? And then you ask them. We're not going to go over all the details that you need to ask the patient, but you basically talk to the patient, examine them, try to get an understanding, at least the basics of why are you here today. Some patients say, we'll give you a really convoluted answer. You need to say, yeah, you have to be really nice. You have to be really gentle. Those are people who are stressed in the hospital. They're sick. They're not maybe at their baseline. And you need to be really gentle. You need to direct them. And sometimes you need to get out of them the most important first question. Other important questions are there, but the most important first question is, what made you come to the ED today? Today, why today? Okay. And then they'll say, I'm short of breath. Were you short of breath last week? Yes. But why? So why did you come today? They will say, well, last week I was short of breath if I walked a mile. Today I can get out of my bed. Okay. So you start to know more about the patient. You start to know more and more about the patient that way. And then you ask them either the old cards or whatever way you want to ask them to learn more about the history of present illness. And then you do your physical exam. And at that point, you should be able to kind of go back, get a sheet of paper, spend 2 or 3 minutes, develop your diagnosis and your plan. Use up to date. Use whatever program you can use. Yeah, maybe go back, okay? There's no master, okay? You can go back. No, there's no master, no. And then you can create a plan, okay? Use up to date. If it's your first time treating a pneumonia, try to you can go to up to date and they have really good charts of what you need to give someone with pneumonia. Okay, we should know about it, but it's okay if you want to refresh your memory, if you want something to look at again, look at up to date. Up to date would have a really good chart and it will ask you all these questions. Is the patient risk for a I'm sorry, a MRSA? Is the patient a risk for a pseudomonas? Is the patient? And you'll go through it and then you'll come up with a plan. Make sure you have the doses also correct. Does the patient have renal failure, kidney failure? I'm sorry, renal failure, liver failure, all that stuff. Make sure you look at that. Look at the patient's allergy list. Make sure that the patient, is not allergic to penicillin, or the patient is not allergic to vancomycin, whatever. Um, you're not going to ask your attending or your upper, what should I treat this patient with? Okay. This is not an appropriate question unless you really are clueless and this is a really difficult question, patient. I mean, you'll run into patients that are difficult and you need to ask questions, but never ask, what do I do? Okay, always tell them this is my plan because I think this is a patient with pneumonia, uh, who's been, a readmit and he failed outpatient therapy with this antibiotic. And I think I should do this antibiotic instead because it would be better coverage for this bacteria, whatever, and then they can, once you run it by your upper or your attending, again, depend on how it's done at your program. Each program, they have their own rules, so usually we, depends on the program. Sometimes you run it by your attending, sometimes you run it by your upper. So once you have the plan confirmed with them, one of them or both of them, you need to come back and place the orders really quick. Generally speaking, you need to place an order within 30 minutes of when you get the call about the patient. So you got a call at 12 or at 2 p.m. Order should be in by 2:30. Okay. We're not going to go over the orders. I don't think we have enough time, and that's kind of a different discussion by itself. But you need to make sure what they look for at the orders. You got to make sure that if the place has um, if you need telemetry or not, what are the parameters for the telemetry? You need to make sure if they need to be bed bound or not. All the diet orders, all that stuff needs to be in there, not just, admit patients with an antibiotic and that's it. Most, if not all, hospitals are going to have an order set. Okay. You need to ask your upper on day one before you start getting patients, hey, and possibly they might have a week or 2 weeks. Sometimes some programs only have a day or two as an orientation. You need to get to know the order sets, and you need to put them in your favorites. Okay, put that in and make sure that you know where to go when a patient comes in. You're not just calling people try to figure out things, when you get a patient. And then if you have time, you need to write your note. If you have some other orders that you need to put in for other patients, or if you got discharge a patient or something like that, It depends on how quick, but H HMP needs to go in quick. Okay. So within an hour of getting a patient, you need to have a HMP done. Again, there is going to be a template for HMP. Ask about it, put it on your favorites. Okay. Um, so I think that should cover everything. Again, typically it should take you about an hour by the time you see a complicated patient until the HMP is submitted. And if you have a really easy patient, never been to the hospital, coming in for cellulitis, they failed outpatient therapy, and there's nothing really else going on with them, I mean, that should be a 30-minute or a 40-minute admit. Um, but anyhow, um, now, existing patient, I'm going to dive in a little bit more into chart check here because I think there's the same information applies for new patient, but there's a little bit more here. So we need to focus that. So when you first go in the morning, go in early. My advice for my wife when she got into residency is that I wanted her to be there 30 minutes early. And I think she's doing that, you know. She's supposed to be at 6, she goes in at 5:30. That gives you some lead time because some of us are slower than others, and it looks really good when you are early. Okay. And it gives you more time to spend chart checking patients, and the first year you need that. Okay, you absolutely need that extra 30 minutes in the morning. It makes a big difference. So go in early by about 30 minutes. Okay, this is my advice. If you think this is going to be a lot for you, and it would create I guess an imbalance in your life and your work, and it's going to be too much for you, then don't do it. But if you start to if it makes your day easier and you enjoy it, then I would recommend that you keep doing it. But anyhow, this is something I did it, and I asked my wife to do it, and doesn't mean that it would work for you, but I highly anyways. So chart checking, you want to look for these things. And when you go in on your first day, again, when you're doing rotation, orientation, make sure you set up your epic the way maybe your upper is doing it, or if you know what you're doing the way you want it to be done. Okay. This is the time for you to work on the EMR, to set up the EMR the way you want it to be done. Okay, not in week 3 while you're getting patient and you're slammed and you don't have time. So this is the time for you to spend time with the EMR, try to get to know it, try to customize it the way you feel comfortable. And you're going to modify it as you go. Okay, it's not set in stone, but this is the time for you to get acquainted with it. But anyhow, so you need to look for these things, and there are a lot more, but this is the things that we need to make sure that we get from chart check in the morning. Okay, and I might be missing something here and there. If you ever think of something I missed, please let me know. But anyhow, so you need to look for the vitals. You need to look for the INO. You need to look for the labs, microbiology. Is there any order that came in? I'm sorry. Is there any order that came in? Is there any? I'm sorry. Any of the microbiology that got updated or anything like that? Any results that came in now? You need to look at images. Sometimes you get an MRI before you leave, and in the morning it gets red. You need to be the first one to know about it. Don't let your attending tell you that. And during morning rounds, hey, did you see the CT scan that we ordered yesterday? You shouldn't be clueless, okay? And don't skip any of those sections because you think there's nothing there. You don't know, because maybe the night team had to order a chest x-ray that showed, I don't know, pneumothorax. I don't know, so you need to make sure you click on all these things. And then current orders. This is really important. You do that in the morning and you do that before you leave. You got to make sure that if you're giving patients recephin and doxycycline and you're giving them IV fluids, those orders are in. Okay. If your attending told you do orders for 10 hours, you got to look at the detail of that order and make sure it's correct. Okay. You got to make sure there are no new orders from overnight. Maybe you say vancomycin and Zosyn, and you're like, why is there vancomycin? The patient needs to be on doxy and Rocephin. And then you look at the handout from the night team, and it says that the patient got really worse, for example. I don't know. And then they brought in the antibiotic. I'm just giving a very general example. Do this in the morning and at night. If you see any discrepancy, ask your upper, okay, and that you cannot explain. Ask your upper, be like, hey, we had the patient plan to be on so and so, but I see there's a change in plan. And then you can also look at the detail for the order, and it will tell you who put that order in. So let's say, you guys have ID consulted, and then the ID infectious disease start changing orders. Then you go to the infectious disease note, and then you make sure you read it and all that stuff. Oh, actually, speaking about notes, I need to add that to the chart check. You need to look at the notes. Make sure you look at the notes from the day before and make sure that no one has left a note. Sometimes they'll submit a note and it will show in the morning, even though they only had it pending for a while. Once you get to note to use Epic, you'll know what I'm talking about. Some specialists or consults, they'll create appended notes while they're seeing patients, and they'll sign it at the end of the day. So it will show up at the morning time. And if you come in the evening or next day, you forget maybe to look at the morning because you think you looked at all the notes that have been submitted in the morning. But it's actually going to be there, okay? Because it was created in the morning, but signed in the afternoon, but it'll still show in the morning, okay? So just make sure you glance at the notes section. Make sure you've read all the notes. If there is a note that's in bold, that means you haven't read it yet. Make sure you read it again, okay? So as you're looking at as you're chart checking, you need to be really efficient about this, but you need notes. Without creating a note yourself about what you're thinking right now, you'll forget it by the time you're presenting to your attending or by the time you see the patient. For example, you're looking at INO, and INO shows that the patient is not producing enough urine. So you create a note to yourself says, check the patient, bladder scanner. I want to scan their bladder, make sure they're making urine and they're not retaining any urine. But then you'll forget it if you don't write it down. Okay, so make sure you write that down. This is how I do it. There are multiple ways that this can be done. This is how I do it. Okay. If some of you guys are using Epic, I know not everyone, but I think probably many of you are going to be using Epic. There is something called sticky note in Epic, and I Googled this and I found a few things that I can kind of show you guys how to get it done. If you see the arrow on the top left corner, you see that there's a blue and there's yellow notes. The blue one, that's something that would be permanent, I think, is going to be permanent in patient record and everyone can see it. The yellow one, that's only you can see it. Okay. And once you click on it, I think either one click or double click, if you see the second arrow on the kind of in the middle or maybe the bottom right corner in this image, that's what it's going to show. And then you can write it down. The way I do it, I say 50-year-old female. I write 50 YOF. Okay, I try to keep it really, really neat and compact. I don't like to write too much in this. And I say P/W presented with pneumonia, period. On Recephin and Doxy, period. I don't know why I keep using this example. I need to come up with a different example. But anyways, was on 5 liter yesterday, comma, weaning oxygen down, period. Need placement, period. Um, uh, Overnight, comma, vomited once. Need to ask patient or something like that. So I'll write that down. I try to avoid writing too much in there. Okay. But this is really helpful for me. Once that is created, this is another thing I found online. you can add it to your patient list. So each one of you will have a list created for all the patients that you need to see. Patient so and so, John Smith, and then it'll have the room number on the left side. You probably guys have seen it doing observership or during medical school. So you'll have it all the room number and then the patient name. Okay, but you can create this and you can edit it in so many ways. On this slide, what is shown is how to add another column, how to add another, whatever you want. You can add the code status. You can add how many days the patient has been there. There are a few things that are built into Epic that you can add into the list. One thing is sticky note. So the reason why I like to add the sticky note to my patient list is when I print that list and I go see the patient, all my notes are already there. I don't have to handwrite anything. Now, realistically, you're probably going to handwrite. I do advise that you leave a blank note at the very end, and that way you can add any notes, okay? Because sometimes when you see patients, they're going to tell you something and you need to address, or you need to talk to your attending about, or whatever. And that's when you go out of the room and then you write it down really quick, okay? Or maybe in the room, I don't know. If there's a safe place for you to write it out, I would, whatever, whichever way you want to do it. Oh, and when you on that patient list page, okay, you can add the sticky note that has the details that you wrote, and you can also add another button for you to click to add or edit any note from the patient list. You don't have to go into the patient chart to create a sticky note. You can create a sticky note from the actual list. This is helpful because sometimes I'm looking over them and I need to edit something really quick. So it's just helpful. So now we're still into that patient care section of your duties. Okay. What about existing patients? I think that's still, yeah. So you do encounter, and then the main focus on the encounter during an existing patient, that's someone you've seen yesterday and you're seeing today, is you need to say how the patient is responding to therapy. What are the new symptoms or problems that the patient has? What new adverse reaction they had to a medicine? You need to ask them all that stuff. You need to do a good review of system as well. Explain the plan to the patient. Okay, and explain the diagnosis to the patient. You'll be surprised that some patients don't know why they're there. Ask them, be like, do you understand? Do you understand why you're here? Do you have any questions for me? Actually, do the exam first. Listen to the patient, do that stuff. Patients really like to be, um, um, I was about to say something about that and I forgot what it was. But anyways, listen to the patient. If the patients say that they're hurting, sit down, listen to them, talk to them. Patients like that, but you also need that for your own to practice medicine. You need to know what's going on with the patient. And then at the end, once you have done all that stuff, you need to ask them, do you have any questions for me? Okay. And if there are family in there, you ask the family as well, do you have any questions for me? If you don't know the answer, you can just let them know. I'll talk with my attending and we will let you know. And once your attending rounds on them, or if he wants you to go back and talk to them, then you should. Okay. And then obviously this is just pretty much a copy paste of the other one. Even for existing patients, you need to make sure that the diagnosis is still correct. Patient is responding to the therapy that you're giving them appropriately, and you need to place any new orders, any changes, anything like that, and you need to write your progress note as well. Okay. I wrote an hour. I think I just copy paste for the new patient, but this whole cycle for a patient that you just saw, I'm sorry, you saw yesterday, you're seeing today, probably should take you with the note about 20 minutes, 15 minutes, maybe 25 minutes. It depends on how complicated patients are. So this is about your interaction with your attending. Don't ask them questions that you can find on UpToDate. And I'm not discouraging you from asking them, but you should reserve all the questions to things that you cannot understand or things that you cannot find. You don't need to ask them, what class of CKD is this patient? Well, you need to find that out. You have the information. You know what the GFR. You need to find that out. You don't ask your attending that question. You don't ask the question of, what do I give this patient now? Well, patient comes in with CHF exacerbation. The patient needs, higher dose of Lasix. You need to form that plan and you need to ask them, hey, this is my plan. Are you okay with it? I'm going to hold the lisinopril. I'm going to give them going to double the dose of Lasix and give it IV. Or, basically they're on 40, give 40 IV. That's considered doubling it. Are you okay with that plan? Okay. You need to know that patients coming in with CHF exacerbation, you need to do strict INO, which means the nurse would have to document every intake and output. All that stuff should be common knowledge that you need to know. You don't ask your attending, hey, what to do? This patient comes in with CHF. That's not appropriate. Okay. And ask your upper or someone who's worked with with this attending, how should I present my how should I do my presentation? Some attendings like the presentation to be detailed, others would like it to be really concise. I had one of my attending at some point who wanted the presentation to be a 50-year-old female. This is our, if this is an old patient, 50-year-old female, came in for pneumonia or came in for CHF exacerbation or came in for cellulitis, whatever. She's on this medicine. She's doing much better today. That's it. That's all he wants to know. Other doctors want me to tell him, then, kind of who's the patient, and they want to know. Some of them doesn't want to know the pertinent HMP. They want to know everything about the past medical history. I'm sorry, like literally everything, and they would like me to tell them all of the labs and read it out for them. And they would like, they were really did. They want me to write all the orders that were given to the patient and give them. And it was really exhausting. And, rounding with those physicians, actually only one physician, he was only one like that, used to take us about 2 hours to 3 hours just doing morning table rounds because he wanted everything to be told to him. So that's just the way he wants it to be done. And he wanted to know who is the PCP and who is the social worker that saw them and all that stuff. So you need to ask your upper and your peers who have worked with this patient, with this attending, what do they want to know from me in the morning? Okay. And I wrote just like few things, you need to make sure that you cover. These are the bare minimum. Okay. This is what you need to cover during morning round. Who's the patient? Why the patient is here. That's important. You need to know if someone took your list away and asked you about each patient of yours, you need to have it. You need to know, I don't want to say have it memorized, but you just need to understand who is the patient, why the patient is here, and what are you giving them for each one of your patients. Okay? Because sometimes, even when you graduate, someone is going to stop by and they'll ask you, like, you have surgery consulted, and they'll talk to you like, hey, by the way, that patient room so and so, what do we have them on? Do we have them on any antibiotic? And you need to know that, you need to, just like you stop the surgeon in the, on the hallway and you tell them, hey, patient so and so, what are your plans for them today? They need to know what they want to do for them today. I'm not sure what specialty any of you guys are, but whichever one it is, you need to be able to know what your patients are, who your patients are, why are they here, and what is being done for them. That's just kind of the bare minimum of medicine about each patient. And be mindful of anything that happened overnight. Okay. Medication, again, I cannot stress enough that your attending is probably not going to know what's the dose of, all the medications for all the GFR or all the liver dysfunction if your patient has one. You need to find that out, and you need to tell your attending, hey, this is the patient GFR, this is the antibiotic I want to give them up to date, this is the dose that we need to give this patient, period. Okay. Or if you want to use other resources than up to date, more than welcome. Up to date is not the only resource, but this is the one that I use and I'm familiar with. Consults, when you call, some hospitals let you put the consult on the computer, others you would have to call it in. If you're calling in a consult, you need to practice before you call the consult, okay? Make sure you know your patients and you have practiced the presentation a couple times before you pick up that phone and call. Don't just pick up that phone and call them, because they might be asking you questions. You need to have your presentation pretty concise and informative, and you need to know why you're calling them, because that's the kind of an important question that they're waiting to hear. This is a patient so and so, this and this and this and that, and you're like, okay, now I know about the patient, but why you're calling me, right? Anyone needs to know that. So you can say, the patient has been having a positive FOBT or fecal occult blood testing, and we need, the patient has required blood transfusion, and we're asking you to do a scope, right? So that's, for example, you calling a GI doctor, whatever. You don't just consult anyone without the consent if you're attending, or maybe your upper, again, depending on the culture, or how's your residencies run. Some attendings are really involved, others are not, and you just need to know how they're going to do it. Some let the upper make those simple decisions, like, I'm not sure, consulting, well, I don't know, a service that routinely consult on that kind of patient, for example, while others want you to ask them everything. So again, you need to know the physician that you're working with, and you need to know the culture of that place that you're working at. Discharge, once you get to, patient is doing good now, you need to make sure that you are ready to discharge patient. One thing you need to be aware of, some hospitals got a rule that you got to discharge most of your patients by 10 a.m. or 9 or 11, okay? So you got to make sure that you do that, okay? Make sure that when you see the patient, you explain to them that they're leaving today. Make sure you explain to them the plan. If you're giving them an antibiotic, tell them, I'm going to give you an antibiotic. Make sure you pick that up, and make sure you take the antibiotic. If the antibiotic is once a day, you tell them it's once a day. If you don't know at the time you're talking to them, let them know you're going to write the instructions for them, okay? When you put the orders in, if the hospital has what's called med to bed, make sure you let them know that. You should be like, hey, they're gonna bring the medicine to you. Some of those programs, it's basically a pharmacy at the hospital that bring medicine to the patient's bed before they leave, so that they don't have to go to the pharmacy when they're really sick and try to pick it up. Okay. But they have hours. So if you're working on Sunday and they're not open on Sunday, you ask them, what's the pharmacy you use? And they say, oh, I use and they give you a name for a small family-run pharmacy that they're also closed on Sunday. So you need to tell them, well, we can't pick that up today from that pharmacy. I'm going to send it to Walmart or Walgreens, or just make sure you know what you're sending, where you're sending that medicine to. Okay. And then notes. Those notes, they can wait about 24 hours, ideally, and best thing for you. So you don't forget if the patient says, If the patient has a symptom that you need to write down, if the patient says something you need to write down, make sure you ask the patient. Make sure you do the notes the same day, so you remember what you asked the patient, you remember what you talked about. If you do it next day, you may forget about it. I highly encourage you, don't leave the hospital with anything, pended or with anything to do. Okay, so that was the patient care aspect of it. And the next thing is professional development. Now I think, we can spend about the same time that we spent with patient care, but I'm going to keep this brief. Feedback. Ask your attending by the end of each week, or depending on how long you with them, but ideally after each week, you ask them, how did I do? Or you can ask them a better way. I used to ask, instead of saying, hey, how did I do? And they can say, oh, you did bad. Or they're probably not going to say that, but that kind of put them in for some attendings, it could be uncomfortable try to talk about this, but the best way you can ask is, can you please tell me what can I do to improve? And then, it's just sometimes you'll be surprised that they say, I think, you need to work on your presentation, or I think you need to work on your chart checking, or I think you need to work on your, I don't know, whatever is you're not doing right, they'll tell you about it. So instead of you telling them, how did I do? And then they just be kind of pushed to choose between good and bad, you can just tell them, hey, is there anything that you can please help me? Well, how can I put it? Yeah, you can just say, hey, can you please help me? Is there anything I can do to improve on myself, or whatever? And then they should be more open and comfortable sharing with you anything that you need to work on. So that's the first thing, feedback that would help you in your professional development. The second thing is time management. Generally speaking, after you've seen the patient, after you done chart check-in, you're back at your desk. There are priorities that you need to understand. Orders are first, before notes. So, you're at your desk, you already talked to your attending about all of your guys, and you know what orders you need to put in. But you also need to work on your discharge summaries. You need to work on your progress notes. You need to work on all that stuff, right? But the first thing first are the orders. So when you first come back to your desk, you need to make sure that you start with your orders. You need to discharge someone or whatever, or you need to put in a diet for someone. You need to make someone MPO. You need to go up on the IV fluid rate. You need to change the pressor from Levophed to Neo or whatever. You need to make sure that you address all those stuff, and you need to know which one is more important and which one you need to put in first. Each one would take you a minute or two, but you have to be mindful. I think we talked briefly, an admission should be 40 minutes to an hour. Chart check-in in the morning shouldn't take you more than an hour. Seeing patients shouldn't take you more than an hour and a half or 2 hours or an hour, depends on how bad it's your list and how many patients you're seeing and how far each patient are. Some places would make you go to different towers and all that stuff. So just be mindful of all that stuff. And I think I talked briefly about you making it half an hour early. This is a personal choice. I just don't want this. I don't want you to do this and then end up being really stressed and lack of sleep or anything like that. But if you can do it, it might help you. This is what I recommended my wife to do. But anyhow, it's something you might want to try, but I don't want you to be too hard on yourself with that. You're not required to do it. It's just something, especially with her and you guys being IMG, it might be a little bit difficult for you, especially maybe the first month or two, as far as chart check-in. You're not as fast as reading the notes. You're not as So it might be helpful, but again, if it's too much for you, or if it's something that's not working, you're not required to do that. And no one would expect you to do it, okay? And another thing as far as professional development would be research and you getting to know people. Research is research. That's a whole thing. I don't think we have time to go into it now, but just know as part of you being in a residency program, and you being exposed to all the newest, um, um, or I guess being updated on the newest developments in medicine, you should be able to take part of that in advance and all that stuff. So again, that's a whole different discussion. I don't have time right now to go into it, but it's definitely important. Grow your network. That's really important. Go to conferences. There are fellows around you. Try to get to know them. Program directors for a fellowship. Get to know them if it's something you're interested in. And then you can do posters. You can do this and that, and you can have people know you more. So how I did it, I think this is the last slide. So this is, you don't have to do it the same way, but this is what worked for me. There was an Egyptian attending once advised me, and I honestly did not take his advice seriously when he first said it, and it kind of I started to understand it maybe halfway through my residency program. He said, "You cannot do it by yourself. You need God's help. Be very close to Him." Because you're going to have highs and lows during your internship year and throughout residency and maybe throughout practicing medicine. You're going to have a good day, you're going to have a difficult day, you're going to have a difficult situation, you're going to have a uncomfortable interaction with whether staff in the hospital, whatever, you're going to have those things. So you need to be able to, you need guidance. And I think, being close to God is kind of the best guidance you can have. It's irreplaceable. You really cannot do it by yourself. But that's my advice. And one of the cardiologists I rotated with in medical school, he told me there are 3 A's to medicine that you need to get all of them: availability, fidelity, and ability. And affability, for if you guys don't know, it means being pleasant, being approachable, and being relatable to patients. And you'll be surprised that the affability is the most important thing, especially with patients. Again, if you don't listen to them, if you don't talk to them, they're not going to tell you what's wrong with them, and you won't know what you're treating. Happens rarely, but sometimes patients come to the hospital and no one really try to understand why they're there. They're short of breath, but they've been short of breath for years. Their leg is swollen or whatever, but they've been the same way, and but if you come close to them, you might know that they don't have money to pay for their medicine, or they've been neglected, or the nursing home that they're at is not taking good care of them, whatever. So and same thing goes when your interaction with your peers, with the consuls that you ask to follow you with the case, with the nurses that are working with you on the case. If you are nice, if you are approachable, people will come and talk to you, and they'll tell you, everything you need to know without barriers. Um, People are nice, especially when you go to a residency program that is not malignant. Most of your attendings are going to be nice to you. They're going to be very respectful, but that doesn't mean you're doing well. That doesn't mean you're doing great, or that doesn't mean you're doing bad. Okay, it's just a courtesy. It's a professional thing. People are nice. Um, you need to have your own expectation. If you do good and you feel comfortable and you feel satisfied, and you've asked your attendings if there's anything you can improve on, and then you just keep doing what you're doing. But just because someone is nice with you doesn't mean that you're doing something good. Okay. And the other way is if you're in a malignant program, God forbid, I hope none of you guys go to a malignant program, but if you are in a malignant program, um, just because someone is rude to you, that shouldn't discourage you from doing what you're doing either. Okay. You're going to find people that hate you. You're going to find people that like you in life and medicine, just about everywhere. You need to have a little bit of, thick skin and just try to understand what's going on. Okay. And set time for prayer. I think while you're there, you're going to probably pray twice at noon and maybe around 3 or 4. Um, it should take you 5 minutes. Shouldn't take more than that. That's my advice, and this is how I did it. I think that's all. I think that's everything I've got.
Thank you very much, Dr. Baldawi, for the great presentation and the tips. Actually, it was really impressive. The things that I would like to just recap on or highlight is the medications, because actually our relationship with the patients mainly based on medications. So sometimes you write in your note, continue insulin or continue heparin, but we help the heparin for a bleeding issue or something like that, or a procedure. So one of my attendings advised me to pull up the medication list side by side with my note while I'm writing my note and look at the medication. Why the patient has ceftriaxone and I don't have any explanation to it in my note, or vice versa. Some medications, they need to be reflected very accurately in your note. And the main things, I think I'll call them accessories. Sometimes, or most of the times, IMGs, they don't pay attention to these things. Accessories, I mean, Foley catheter, nasal cannula, feeding tube. There are things that you can discharge patient with and things that you cannot discharge patient with. And it depends on where the patient is going, because most of the I would say non-American countries, they don't have just like here sniff and rehab and all these stuff. So either they go home or they stay in the hospital forever. So you have to familiarize yourself. And if you would like to be fancy with your admission during the HPI, you can mention where the patient is coming from. Is he coming from home or they are coming from rehab? This will help your attending and social worker to make a plan for discharge, because the plan of discharge starts on day one. You guys are able to hear me, right?
Yes, we can.
Perfect. And the last tip that I would like to focus on, and Dr. Baldawi also mentioned, that good communication, especially with your patients and senior residents and attendings. Some of the senior residents, they place orders for you, for your patients during round. So make sure that you communicate with them. Hey, will you place orders for me, for my patients, or you want me to put the order? Because first, we don't want duplication. Second, we don't want the senior, he thought that you're doing it and you're not doing it, and no one place orders for the patients. So these are like take home points that I would like to highlight from the great presentation. And I will leave the meeting for Marwa to ask the questions that the attendees asked in the chat. Thank you very much.
Thank you very much, Dr. Baldawi, and thank you very much, Dr. Amar, for this amazing hour. It's really fruitful, and they were very good advices for us for starting our residencies. So I'll be transferring to you some of the questions in the Q&A in the chat. Hopefully, you can reply to them.
Sure.
First question: shall we rely on unsigned notes? I mean, shall we take these notes in consideration to change the plan?
Uh, I would say yes and no. So if there is, I wouldn't, if they said in their unsigned note, I mean, if you want the official answer would be no, you shouldn't until it's signed. But if they say, if the surgery has pending notes that saying planning for surgery tomorrow, just keep it at the back of your mind to go back and check on that note. Make sure once it's signed, you go and you put the MPO and you go and you hold the heparin or whatever. If you're about to give the patient, let's say Eliquis, try to reach out to them before 9 because usually that's when hospitals give or nurses, I'm sorry, give medicine. Just text either, I'm sorry, not text, but like, use that chat on Epic. Just be like, hey, I see in your appended note you're planning for surgery tomorrow. I just want to make sure, do you want me to hold Eliquis for today? Okay. So again, I wouldn't take it and change anything significantly until it's signed. But if there's something I need to address right now before 9 a.m. or before 8 a.m. or before something is given, I would reach out to them, just confirm with them.
Okay, that was great advice. Thank you, Dr. Al-Beldawi. Here's another
Okay.
question. As an NUS IMG, beside the advices you told us, what can we do now to be ready? Oh, that's a really good question. So yeah, what can we do now to be ready? Do we need to practice typing fast? And also for up to date, sometimes explanation of the disease is too long. If we are in a fast paced environment, what other sources do you recommend? What can we use?
So here's how I used to do it. I'll leave preparing now for, a little bit at the end of my answer. But as far as up to date, when you click on it, there is summary and recommendation tab. If you're seeing patients and you got 10, you got a full list, you are probably not going to have time to read up-to-date article on atrial fibrillation. It is too long, right? So I would read the summary and recommend, because you should already know the basics, right? You just need to know few things. So I would read the summary and recommendation, and I try to kind of get to answer my question that way. If that does not answer my question, you can use Control F on the keyboard and you can write down, let's say, beta blocker, and it would search the whole article and it would tell you where are beta blockers mentioned. And then you can go and just read that section really quick if you think that would answer your question. So that would be kind of how to use up to date. Once you're back home, I would pull up that article that I needed to learn about today because I'll remember reading a few things here and there. I'm like, oh, that's something new. I never knew about it. I'll go back home and I'll read it again. I'll read the whole article. I'll just kind of read it on my own time. Okay. So that's how I used to do up to date. And I think I read everything about up to date. Probably read it all. Mixapp is another resource that you can use. Keep in mind, Mixapp, if you guys are internal medicine, I know not everyone is probably going into internal medicine, but if you are, they'll give you Mixapp or something similar. Mixapp is not updated to today's data. They're updated to what the board is going to ask you. And I think the board would only ask up to like a year ago or something like that. So just be mindful of that. So that's why I'd like to rely on either research, current research, or up to date, which basically they read the guidelines. Yeah, I'm sorry, I rely mainly on not the research, I'm sorry, the guidelines for, let's say, ISD or whatever. Um, American Heart Association, or whichever one you need to know. That's another way you can Google and you can put all those guidelines and you can keep them into your favorites. And if you need something related to heart, you go to Heart Association, or you can just go to up to date, go to the summary and recommendations. If you can't find it, search it within the article so you can find it. So that's as far as up to date and how to find information and other resources that you can find. As far as now, how to prepare for now, definitely how fast you type is important. There are free websites online that'll teach you how to type with 10 fingers instead of I think most of us type with 10 fingers now, but there are people that type with like one finger, try to find each letter. Obviously that's too slow. You can't do that. So you know, you need to place both hands on the keyboard and try to, you don't really look at the keyboard. You need to know where everything goes. And there are tools online. And if I find one, I'll share it with you guys later on. But I'm sure if you Google online, you know, typing for free tapping practices or free tapping tutorials or something like that, I'm sure you'll come across a couple websites that'll teach you how to do it. So that's one thing. It's an excellent idea that you guys proposed. You know, as far as typing is, that's good. As far as medical knowledge, um, that what I did, I forgot the name of the book actually. Let me look it up really quick while you guys are. I think it was for John Hopkins, internal medicine review. Yeah, board review book. But I think this is not updated that frequently. When I was going to internal medicine, that's the book that I studied, and it looks almost the same as the one that I did. So I'm not sure if being updated frequently. So this book was not humongous. It was something doable in 2 to 3 months for me. Okay. And they also had um, um, quizzes at the end of each section that I was able to take and just, you know, do them. And I think what I did, I tried to do things that I'm either a weak, like a subject that's my weakness, or something that I just frequently encounter. So I did the cardiology section really well. I think I went maybe over ID and what else did I do? I forgot really. It's been like 5, 6 years. But anyways, so I picked 3 or 4 chapters that I've focused on, and the rest I just read the just like the highlights of the chapter. I try not to go too much into it. But again, this book when I'm reading it, has not been updated. The one that I have is since 2015, so that's obviously not going to be the one that you want. If your program can give you the um, Mixab books, I would look into that. If you find other board review books, I would look into that. Harrison is another good book that you can look into, but definitely pick up any board review medicine and just try to go over the basics. Try to refresh your memory of all the basics. I would encourage you not to take detailed notes because that's not the point. The point is for you to go over everything really quick, things that you have already known, things that you already studied, but just look at if you're a surgeon or if you're in a surgery, a residency, pick up the board review for surgery. You know, I don't really know anything about that, but you know, so that's what I would advise you guys to start and make it quick, make it detailed, you know, don't, I'm sorry, make it quick, make it kind of general. Don't try to write down every little detail and take an hour or two to finish one page. That's not the point. The point is for you to refresh your memory and just kind of get a gist of what's going on and move on. Okay. And if there are any questions, I would encourage you to do like 20 questions a day, 25 questions a day. How many days do we have till you guys start? Maybe a month and a half now? I think a
Yes,
month and a half.
almost there. Maybe
Yeah,
less.
maybe less. Yeah. So maybe you have about 40 days, 50 days. If you finish 20 questions a day, that's about 800 or 1,000. I think that should get you, along with reading, you know, the basics on each of those books. I think you should be ready to go.
Thank you for your answer, Dr. Beldawi. Those were great advices.
Thank you.
Yeah, we'll start at June 24th. So yeah, not too much.
Okay. Okay.
Yeah. So here's one last question. He says, as you mentioned, one of the doctors is asking, as you mentioned in the presentation, there are things that might be do not miss orders that we as a new intern might not be aware of. So, for example, DVT prophylaxis, fluid maintenance, diet. So, is there a guide that you can recommend to us so that those basic things won't be missed for all patients, and what needs to be considered?
Um, One thing that helps you significantly, and even helps me now, especially if I'm seeing a very high volume, but it can help anyone, is this order sets. I know some people like to stay away from order set if they feel that it limits how much they can do. But to me, it helps me not forget important orders. So again, on your first day, when you're doing rotate and orientation, ask them, hey, I need to make sure that I put order sets on my favorites. So when you're doing the admit in the order set, most hospitals that I've worked at in the order set, they would have, the diet, they'll have PRA. You'll have to click on them, but they'll have the option for a diet, PRN, pain medicine, for example, like Tylenol or something. I'm not talking about something you don't have to put a morphine PRN. That's not, I would not recommend that. But, definitely like, something for mild pain, something for nausea, um, something for the, obviously DVD prophylaxis, the IV fluids, and um, telemetry if you need it. If your place does not have an order set, which I have not come across any place that do not. But if your place does not, I would just create you know, a, s- a page and just write down on it everything that I need to do. And when I'm doing my notes, I'm sorry, when I'm doing my orders, I'll just look at that page. I'll just tag it on your cubicle, on the side of the wall or somewhere. Every time you're doing an admit, just look at that page and make sure everything you wrote or on that note, everything you wrote on that note is something that you've done and move on. And that's the best way I can think about it.
All right. Thank you, Dr. Baldai, for answering the question, and
Thank you.
thank you for your valuable hour, for your valuable time, and for all the advices that you gave us to start our residency. Thank you, everyone, all the doctors attending now for participating in this session. Hopefully that was useful for all of you as it was useful to me. Again, appreciate your time, Dr. Baldawi, and we are
Thank
ending the
you.
session now. Have a good one, everyone.